and welcome to the event. My name is Erin Adams, and I'm the Vice President of Human Resources here at the Globe and Mail. And I would like to welcome everybody that's here in the room, as well as everybody that is joining us virtually from across Canada. And before we get started, I wanted to acknowledge that the Globe and Mail headquarters are located on the traditional territory of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. My colleagues and I are grateful for the opportunity to live and work on these lands. So on behalf of the Globe and Mail, I would like to thank everyone, and I would just like to extend a special thanks to our sponsors, to Bayer Canada, who is our presenting sponsor, as well as to Manulife and Desjardins, who are our gold sponsors. We truly appreciate you making today possible. So thank you. Over the next few hours, we are going to be talking about women's health. In particular, we're going to be talking about fertility, perimenopause, and menopause. And while it's fortunate that these are no longer the taboo subjects that they once were, these stages can affect women for years and years during their working lives. And so we need to make sure that there is more attention in the workplace, in society, and in healthcare. And it's great to see that that is happening. So still there's work to be done. We need to ensure that there's equitable access to care for all women, regardless of background, to ensure that they are able to transition through these stages of life with respect and dignity. And here at the Globe, we, over the last couple of years, have been introducing more policies and guides to help support women's health. And when we're looking at our policies and developing them, we try and ensure that they're an educational focus to them, educating managers and colleagues, trying to reduce stigma, trying to create a safe environment where people feel comfortable to raise these issues with their colleagues or their managers, and also recognizing that it's not a one-size-fits-all. So we provide suggestions, and then the manager and the staff and the employee can determine what fits given their situation. So 2 years ago, we introduced a menopause policy, and it was very well received. So usually when we send out new policies, I'm not sure anyone has ever read it, but this one we actually did get a lot of feedback, a lot of positive feedback. Again, the purpose of the menopause policy was to create awareness and really talk about how menopause symptoms can show up in the workplace and provide some suggestions on adjustments that can be made to women's work to make sure that we are able to keep women in the workplace instead of having them leave, often at the prime of their careers. We also have recently introduced a guide for people when they're returning from pregnancy or parental leave. And the impotence of this was we realized when somebody comes back from short-term or long-term disability, we have a really well-defined return to work plan for them. But we didn't have anything for people that were coming back often after 18 months of being away from the workplace. And so again, this guide just offers different suggestions on how to ease your transition back into the workplace. Kind of starts at what you can do kind of a couple months out, a couple weeks out, thinking about what your first week is going to look like. Do you want to start midway through the week instead of on a Monday? It might make your first week a little bit more manageable. Maybe come back part-time hours for the first little bit, depending on kind of your personal situation and whether that works for you. So again, just to provide kind of alternatives to think about. And the last thing I'll talk about more is more from a mental health perspective. So we have partnered with an organization that provides specialized support, trauma support to journalists, and we recognize that female journalists and people, racialized journalists, are the ones that are typically targeted by online trolling and harassment. And so we wanted to make sure that the impacted journalists have access to specialized support, and now we do have that with the company that we've recently partnered with. So we can get started on today's event. We have an excellent lineup of speakers that will share their experiences and their insights. And after the program, we'll be back outside here where the food was, and we'll have a networking event, so I encourage all of you to go out and meet some new people. And so it is my pleasure to introduce and welcome to the stage Victoria Friedrich, and she's the country president and general manager of Pharma Canada with Bayer Inc. And as we welcome Victoria to the stage, please turn your attention to the screens for a special introductory video.
Every single month, blood. So much blood. The lost moments, the sacrifices I've made. Is this heavy period normal?
I've been told it's common in menopause, but my whole body's on fire. Dripping sweat. The sleepless nights, ups and downs. Is it normal I suffer in silence?
The desire's gone, vanished. The growing distance, feeling sad, guilty. Is this quiet battle normal?
Every time we get too close, the anxiety hits. What if I get pregnant? Is this fear normal?
With every period, the cramps, the agony. I'm the one who misses out, can't be there, again. Is this unbearable pain normal?
You know what hurts in women's health? Being told everything is normal. Because if something is holding us back, it's anything but normal. It's time to question what we've been told and confront what we've accepted. It's time to reclaim the moments we've missed. Women by Bayer is here to reveal what's not normal in women's health. Raise your voice and share your story at women.bayer.com. Together, we can create a life without compromise and embrace every single moment.
Good afternoon, everyone. I'm delighted to be here today on behalf of Bayer Canada, the presenting sponsor of this vital conversation. We have an esteemed group of healthcare providers and thought leaders with us, and I appreciate your presence for what promises to be an enlightening discussions for women's health in Canada. This topic is close to my heart and finally receiving the attention it deserves in our workplaces and healthcare systems. However, much work lies ahead. Women in Canada face more barriers to healthcare access and are less likely to express their concern than men. This issue is particularly acute in remote areas, among Indigenous women, and within the 2S LGBTQ+ community. As leaders, we all do need to do more. Today, we'll explore how we can work together to provide better care for women at every life stage. We'll address critical areas like reproduction, postnatal care, and menopause, topics that have been long shrouded in stigma. Today, we gather to break that silence through collaboration and partnership. At Bayer, we believe every girl and woman should have the autonomy to shape her own future. Research shows that access to contraception remains a concern for women, particularly in remote areas and marginalized communities. Approximately 61% of Canadian women experience unplanned pregnancies, which is unacceptable for supporting women's potential. Every woman is unique, and every woman has unique needs, which is why we offer at Bayer over 30 health products and are working to remove barriers to care and redefine a future where women can thrive. We are committed to continuing to address the unmet medical needs, expanding treatment options, especially for menopause. Helping address menopause symptoms is not only better for individuals, it's better for our economy here in Canada. Menopause impacts job performance and contributes to $3.5 billion in costs to the Canadian economy annually. This underscores the urgent need for targeted policies and programs to enhance care for working women. This afternoon, you'll hear from an expert panel, including the Honourable Marjorie Michel, Minister of Health of Canada. Her commitment to social equity and reconciliation with Indigenous communities is inspiring, and we are grateful for her advocacy in ensuring all women have access to birth control. Today's program features 3 interconnected panel sessions focusing on women's health across all different life stages. We will delve into the links between fertility and postnatal health, explore myths surrounding menopause, and discuss disparities faced by women here in Canada, and work hopefully also together to find actionable solutions. Thank you for being here today to kickstart this essential conversation. Together, we can take the insights today into our businesses and personal lives, making strides to bridge gaps in women's health. And I will now hand it over to Anne Huey, health reporter here at the Global Mail.
Thank you, Victoria. Hi, everyone. I'm Anne Huey. I'm the Generations reporter at the Globe and Mail. I'm very happy to be here today. I'm so pleased to be a part of today's event. Women's health impacts every corner of our society, not just the lives of half of our population, but also our families, our communities, the broader society and economy. So it's vital that we continue to raise awareness and normalize these conversations that we're about to have today. We have a big program planned for you this afternoon. We have 3 panel discussions featuring experts from the fields of women's health, and of course, our closing keynote from the Honourable Marjorie Michel, Minister of Health. Also be sure to stay after the end for the networking reception, which will happen at the end of this afternoon. So let's kick off our first panel discussion of the day. Over the next 35 minutes, we will be exploring the health challenges that Canadian women are facing in often overlooked areas. The first of those areas is fertility and preconception, and the second is postpartum and the postnatal period. We will look at where gaps in care currently exist and ideas on how to address them. We have 3 great speakers to share those insights today, so let's introduce them. First, we have Dr. Soni Sierra. She's the reproductive endocrinology and infertility specialist at Trio and Evolve Egg Freeze Clinic, and she is also assistant professor at the University of Toronto. Welcome, Dr. Sierra. Next up, we have Amy Ferguson. She is Vice President of Business Development, Group Benefits, and Retirement Savings at Desjardins Insurance. Welcome, Amy. And last but not least, we have Dr. Lara Gota, Obstetrics and Gynecology, Maternal Fetal Medicine at Mount Sinai Hospital. She's also Assistant Professor of the Department of Obstetrics and Gynecology at the University of Toronto. Welcome, Dr. Gota. On a very personal note, Dr. Gota is also a very important person in my life because she delivered my daughter 5 years ago. So, yes, thank you. Okay, so let's start off by talking about some of the main challenges that women are facing in that first period that we were talking about. So navigating the preconception, planning, and fertility treatment period. I would like to ask each of the panelists for their insight on this. Maybe Dr. Sierra, it makes sense to start with you. Maybe you can tell us a little bit about who it is that you're seeing coming into your practice and some of the challenges that they're facing.
Sure. First of all, thank you for having me here at this very educational and important event. So I see patients across the fertility spectrum. So we see young women, people who are interested in learning about their fertility, who are interested in learning about fertility preservation. I also see women in couples who are facing infertility, who are seeking treatment for that. We also see single parents who want to start families or add to their families. Same-sex couples who want to, again, start families or add to their families. And then I also see women in couples who are facing recurrent early pregnancy loss. So right across the fertility spectrum. And I would say that some of the challenges that they face, one is sometimes a lack of fertility awareness and the lack of limitations of our reproductive biology. So sometimes they present too late, and that might limit their options. Similarly, we're really lucky in the GTA in that we have a very dense network of fertility clinics, so very easily accessible. A lot of them have outreach programs, so we're getting to northern areas, but there's still a huge amount of underserviced or unserviced areas when it comes to fertility that affects their awareness and education and, of course, access to service. The other struggle that we see is along the lines of access, and Ontario's done a really good job. I think we were the first province that started with funding, some federal funding of in vitro or fertility treatment. For the longest time, fertility wasn't seen as a medical diagnosis, or infertility wasn't seen, when in actual fact it should be, because it's a malfunction of your reproductive system. And so it's not covered under our OHIP. But the Ontario government, like I said, they have done a great job with the fertility funding program, which they have recently expanded. So it is increasing access, but it just covers a portion of what's needed. On average, couples that face infertility, they need about 1.6 cycles to take home a baby. And the fertility program covers 1 cycle. And even in doing that, while it's a big help, it doesn't cover the medication or additional costs. Insurance companies are stepping up, and benefit plans are improving, and corporations are standing behind those kinds of plans. But again, there's lots of work to be done around that. I think those are the big struggles.
When you talk about the groups who you're seeing most commonly in your clinic, and then the challenges that they're facing, how have those things changed over the course of your career, or has it basically been the same groups and challenges?
I was just talking to Amy. I'm coming up on my 20th year of practice, and so it has changed. It has changed a lot. So fertility, there's a lot of advances in technology when it comes to IVF. But I think there's a few things that have changed. So one is this whole concept of fertility preservation. When I started, it was a very taboo topic. People didn't talk about it in Canada. I did some of my training in the US, and people were having egg freezing parties, and that wasn't happening in Toronto. And so that has changed, because now it's become very mainstream on all social media avenues. So people are talking about it, which is great because it's increasing awareness and access. The other way that, similarly, things like recurrent early pregnancy loss. So again, it was a very isolating experience for women to have to go through pregnancy loss, not having support amongst their peers, not having support in the workplace, and not having physicians and family doctors who were aware of what was normal in terms of normal reproductive function, and there's a certain risk of early pregnancy loss. But when it happens on a repeated basis, they need referral and sometimes investigations and management. So that awareness has increased. And I think a lot of the taboo around everything in fertility has decreased. So not just with egg freezing, but celebrities and influencers talking about their fertility struggles or their pregnancy losses. I think that's really changed our landscape.
I will move on, but not before I ask what an egg freezing party is and whether that's a real thing.
So an egg freezing party, what it is just a open cocktail party where sometimes there's physicians there, and people come and they talk about their fertility, and they learn about the limitations and egg freezing options.
But they're not actually.
We're not actually doing them. No, we're not doing egg freezing on
It's like when you
no.
said drinking, and I was like, I don't know what's going on here. Okay, Dr. Gota, you work with patients who are managing high-risk conditions or conditions that put them at high risk. What additional challenges are you seeing them face when it comes to this same period, preconception and fertility?
I think it's mostly with respect to time. A lot of these patients were previously told, because of your medically complex situation or diagnosis, you probably can't have a pregnancy. And healthcare at times, medicine has changed in a way that now more people are becoming pregnant, more people are becoming aware that they are able to become pregnant. And so when they come, having not realized it, a lot of them are farther along in careers. And when you're farther along in careers, the more responsibilities you have, the heavier the crown that you wear. And so taking the time off in order to go through fertility, or in some cases for the medically complex patients, optimizing their health in order to maintain a pregnancy, that takes time away from work and time away from busy positions that they may not be able to feel comfortable doing.
And that seems like a perfect segue then into you, Amy. Do you want to just jump right in?
Just jump. Yep, absolutely. I will just tell you that we just made a connection today that many, many years ago, I went through lots of fertility treatments, and it was at the same clinic. So, it's none of that was planned. But, from an employer perspective, 25 years ago when I went through that, it was never discussed. Employers didn't talk about it. I kept it quiet. I didn't feel safe to be able to share that information. And we're seeing that change with employers. So I can speak on behalf of Desjardins as an employer, but also as a benefits provider. It was phenomenal to hear about the Globe and Mail and what's happening here with a focus on menopause and a returning to work after being off on parental or maternity leave. And so we are having more and more questions from our employer clients asking about how they can help their employees, whether it's from implementing benefit programs that are specific to a family focus, a family building program, because we're hearing what happened in Ontario. We have coverage. We were the first. Not every province has coverage. And so we as insurance carriers and as an employer, we have an obligation to support employees with this. And so we're having those conversations, which we didn't used to have. Even 5 years ago, we weren't having those conversations. So it's been really refreshing to have those conversations and help our clients and our own HR team build up the communication to make sure everyone's aware of what's going on.
So let's move on to the postnatal period and talk about some of the biggest challenges that each of you are seeing in your own worlds. Maybe Dr. Sierra, do you want to start with some of the biggest challenges that you're seeing with some of either the patients that are coming in, or I don't know how much aftercare you're.
I don't see them after they have their baby, unless they come by to show off their baby, which is the absolute favorite part of my job. But I will say there's one thing when they finish treatment, and especially with the pregnancy loss patients, there's a little bit of a gap in that I'll follow them until 10 weeks, but sometimes obstetricians won't pick them up until their second trimester. So sometimes there's a little bit of a gap where they're not getting the care and the support that they need. And not every obstetric patient needs that, but there is sometimes some issues around that. The other thing that we see sort of not postnatally but post-treatment, we do work sometimes we need to work with the MFM specialists, high-risk doctors to carry on care, especially in our high-risk patients. And because of the nature of fertility, a lot of our patients are older. And so carrying a pregnancy in your 40s is not the same as carrying a pregnancy in your 30s, and they might need additional care. There's additional risks. And then there's people who use third-party reproduction in terms of donor eggs. So they can be really outside of what a normal obstetric patient is in terms of age. And so that's where, again, we work hand in hand with our MFM colleagues.
Okay. Maybe Dr. Gota, this seems like the perfect place for you to jump in.
I will speak to the postpartum, but again, as Soni was saying with, or Dr. Sierra was saying with the antepartum, and just after conception through IVF or spontaneously, a lot of these patients who have medically complex, and patients in general, pregnancy is an anxiety-inducing time and an anxiety-inducing state. And so I think knowing what they have in terms of supports for mental health as well during the entire process, not just during pregnancy, and significantly in the postpartum period, we're able to manage pregnancies that can become quite dangerous to patients' health at times. And for them, while it's supposed to be the happiest time of their life, it can also, in some cases, be the scariest. And so some of that they carry with them even after babe is born. And so having those supports and knowing what supports they have, I think a lot of patients come back saying that they have a hard time navigating where to find the resources, where to get the supports that they need. And so that might be something that can be brought into workplaces as kind of easy access to information, let alone access to the supports.
Beyond the mental health supports, are there other like physiological
Yeah.
health supports that you
So
see?
I specialize in hypertension, high blood pressure in pregnancy, preeclampsia, and we know that that has a huge impact, not just in the pregnancy period, I'm not ignoring all of you, not just in the pregnancy period, but in patients' long-term cardiovascular health. And so we've also developed kind of across various centers, a fourth trimester clinic, and we don't want to forget that portion because leading into long-term health and going into menopause, patients have cardiovascular risks and metabolic risks that are just because of the effects of pregnancy and the outcomes of their pregnancy events.
Amy, did you want to address some of those supports that Dr. Gotas just mentioned?
Yeah, I love her term of the fourth trimester. I'd never heard that before, so I think that's fabulous. We see a lot of that when we talk about mental health. And when we look at the fertility journey, we know it's impacting all areas of their health, from financial and mental and physical. And when we see them coming back to work, the mental health aspect is even more exacerbated because you have women who are perhaps later in their career at a different level of a role, and they have the anxiety of, how am I going to do everything? And where do I go for help? And not always comfortable to ask for help. And so what we're seeing a lot of is how to help our clients, and even internally, how to build up those communications. Because that's that key piece of, we want to make sure we're giving that information to anyone who's leaving for maternity leave or parental leave, of what they can access during the leave and what they can access when they're coming back. And as an employer, it's really ensuring that you are flexible. And again, when we heard what the Globe is doing, sort of how that return to work is going to happen, and perhaps being able to do it in a slower pace to ensure that those supports are in place.
I'm wondering if you all can address how a person's experience in the one stage can impact the other. So specifically, how someone's experience with preconception or during the course of having fertility treatment, say, can influence their postnatal health outcomes, how it might influence their experience after the fact. Is that something that any of you want to jump in on?
Say, you mentioned it in terms of the sort of mental health impact. So fertility is a difficult road to go down. We always talk about how, it's not the kind of medicine that's prescriptive. You have X problem, you take Y medication, and you get Z outcome. It's more circuitous, and it is a mountain they climb, and there's a lot of starts and stops. There's a lot of unknown. 40% of infertility is still undiagnosed in terms of not having a reason why. So it's difficult for patients to understand, it's difficult for them to cope, and it does breed a lot of anxiety and uncertainty that they take with them on their pregnancy journey. And even sometimes postpartum, when they come back for baby number 2, there's still a lot of anxiety. So we work in our clinic hand in hand with mental health support. We recommend highly that everyone sees a counselor before they start their fertility journey, just to have that extra support as they go through it. We also work with primary care physicians who are managing mood issues prior to coming to us and making sure if they're on any mood stabilizer medications that they know that they're safe to do so. There's no stigma around taking care of that as they're going through their fertility health journey. And then, of course, sending them off to obstetricians to manage after that.
A thought just popped into my head as you were talking about the recommendation for counseling for women who are about to undergo fertility treatments. I'm just curious, how often are the women themselves undergoing counseling or receiving treatment for mental health with partners, or are they often undergoing it alone? This can be for anybody. I'm just mostly curious.
So we had it as a mandatory requirement to present as a couple if it was a couple going through fertility treatment. We've sort of loosened that requirement to being highly recommended, but it is a couple approach because infertility affects the man in the relationship different than the woman, and it's not fair to assume it doesn't affect one or the other, and it affects the family and their home, and so it is important as a couple.
And even just, I would imagine, decreasing that feeling that they're alone in it. Yeah. Okay. Dr. Gota, you were going to join in.
Just with regards to the counseling and undergoing it, even in pregnancy, there are perinatal mental health teams that help with support. It doesn't always have to be a couple. There are single parent by choice families that are created, and but the offer is always there for the patient and any partner or support person that they have, because they experience it differently. And sometimes the best supports that they can have are had separately. So even though they're both undergoing it, they may not necessarily have to do it together, but that it's there and available to them and their supports. And then with regards to the other question that you had before, particularly with patients that we see, medically complex patients who are trying to optimize themselves for a pregnancy, sometimes the challenge is in that first part, if they don't have the optimization, if they don't have the information about how to better improve their glucose and their diabetes before getting pregnant, or improve their blood pressure or their heart disease before, or know that we implement aspirin as a very easy way to prevent preeclampsia or help prevent it, then their postpartum course and their cardiovascular risks, their metabolic risks later are increased. And so I think they're not knowing the information ahead of time and being able to have access to that and implement those interventions can have an effect on them long term.
Amy, did you want to jump in?
Just to add in, we talk a lot about fertility benefits in the industry, which essential. We know that's essential. There was a study done or a survey by Benefits Canada that said 42% of employees would leave an employer if they don't have fertility benefits. So it is something that people are asking for. With that, though, it's not just the drug coverage or covering fees for surrogacy or adoption. It's also the mental health component. And it's essential that companies are looking at expanding the mental health benefit that they have, whether it's expanding the type of practitioners that are covered, because especially when you're going into rural parts of the country. So here in Toronto, we're lucky. Someone living in rural British Columbia or rural Nova Scotia don't have access to the same professionals that we do. So it's really making sure that you're expanding what's covered and the amount of money, because the worst part would be for someone who is struggling, and we're seeing that when mental health is being impacted through the fertility journey, it's exacerbated when they come back to work. And so you want to make sure that there is enough coverage available for the employee and their partner, if there is a partner, to be able to access that help.
So we've talked a lot about challenges that you're seeing among patients who are coming through your offices and with employees as well. What are some potential solutions that you all might have if you have the ear of employers, policymakers, other people in healthcare? What would you like to see happen? Make things easier.
I can jump in from an employer perspective. I think what we're doing here today is a great first step. So having these conversations, we've all said that this didn't happen 5-10 years ago. And I'm seeing employers, including our own, Desjardins, embrace women's health, fertility coverage, and really having those open discussions. I'm sure everyone saw the report that came out from McKinsey, I think it was 2 days ago, the 22nd. We're really excited to partner with the Women's Health Collaborative on, where does that report take us? There was a lot of great information, but making sure that we're making that available to employers so they can really action it. But I would say it really goes back to those HR policies and implementing.
And for those of us who aren't aware of this report, can you just summarize?
I'm hoping someone else will jump in a second, but McKinsey, I think, in 2024 did a global study on women's health, and then they just released, I think, October 22nd. I'm looking around at different people on my team. Do we have... I'm from the Women's Health Collective. Yay!
McKinsey's partnered with us. It's the first time ever that Canada has had an economic impact. Oh, sorry. Thank you. It's the first time ever that Canada has had an economic impact study on women's health. And so it really focuses on the key areas of burden, the drain to the workplace and productivity. But investing in women's health represents a $37 billion opportunity to the Canadian GDP a year by 2040. There were some stats already mentioned around menopause being a $3.5 billion drain to the economy. Mental health is a $20 billion drain to the economy. Endometriosis, fertility, et cetera. So this is really a tool to help us awaken the eyes of public sector, private sector, the government on investing in women is a smart thing to do and it's the right thing to do. And so if you want any more information, happy to talk to anybody after I'm around. So thank you for your sponsorship and partnership. We're really excited to launch the campaign.
We are too.
Thank you
Awesome.
for this work.
Thank you.
What a smart room full of people.
I was just going to say, these policy changes, this attention, it's so important because, as I was mentioning before, this shift in culture and how all these taboo and stigma issues that were there 20 years ago are less so. And it is very important to have workplaces be open and aware of fertility issues and women's health issues, because so many times I've sat in front of a patient and we've mapped out a course of treatment and they're completely stressed because how are they going to get off of work to come here without telling their colleagues, without telling their managers? And so it's just one more layer of stress that conversations and policies will affect top down. It's all positive.
We've talked a lot about the importance of awareness and of having these conversations openly. Beyond that, in each of your worlds, what are some bright spots? What are some positive changes that you've seen that you're excited to share with the rest of the group here?
I think for us, it's the age of family building has increased, and it's also expanded in terms of who is getting pregnant and what families look like. And I think from a health perspective, from patients who are comfortable either leaving work or coming from jobs where they get supported, being able to see more people feel that they can have families and can get pregnant that didn't before is incredibly rewarding. And as part of our preconception clinic, we're seeing people even virtually in consultation for expanding in terms of spreading the word and allowing people the notion that they can family build, which is great.
We're seeing a lot of advances in technology and artificial intelligence and working towards improving accessibility. So things like at-home testing, steps towards at-home monitoring even, to help with that outreach to bring fertility services and treatments to places that classically have not been accessible. So those things are really exciting, and they're going to increase our efficiency in what we do as well. But I think for the most part, the big gain is going to be in accessibility.
And I just wanted to add, when we've talked about the stigma, again, I was one of those people who was sneaking out of work to go for daily blood tests and ultrasounds, and then trying to figure out when you have to go back in the afternoon. And no one should be living through that. And so the fact that so many people are talking about it and we're sharing our stories, it gets rid of the taboo piece of it. And, for us, when I look at, we rolled out our family our family focus offering, and within a year and a half, we had over 1,000 clients that implemented it. So that alone was unheard of 5 years ago. So we're really proud that it's becoming top of mind for employers.
Well, thank you so much, ladies. That was really wonderful. We are at time now, so we'll have to leave it there. As we've heard today, supporting women through fertility, conception, postpartum, and postnatal care requires collaboration from healthcare providers to employers to policymakers. So let's hopefully continue these conversations and work towards a more inclusive, informed, and compassionate care. Please, everybody, thank me, or join me in thanking. No need to thank me. Please join me in thanking Dr. Gota, Amy, and Dr. Sierra for being part of this discussion and for all of your thoughts. Next, I will be handing things off to my colleague, Christy Kirkup, and she will be introducing our next very insightful panel.
Hello, everyone. What a packed room. This is so fantastic to see all of you here today. Thank you so much for being with us. As Anne mentioned, my name is Christy Kirkup. I'm a health reporter at The Globe, and specifically, women's health is one of the areas that I dig into as part of the work that I do. And so it's really wonderful to be here today to have this conversation. And so, as you know, over the next 40 minutes, we're going to be exploring perimenopause and menopause and ways to help Canadian women navigate this transition. These, of course, are not just women's issues, these are societal issues, and the impacts are not only felt at the individual level by women and gender diverse people, but also by families, by communities, workplaces, and in our economy. Often people say that they are ill-equipped for this chapter of life, often because this was not a conversation like the one we're having today. And so that's why it's really critical to have discussions like this, to eliminate stigma, to help to eliminate stigma, and to also bolster awareness and knowledge. And so that's why we are so fortunate to have 4 wonderful members on this panel today to share their insights. And so I'm going to start by introducing them. So first we have Corey Lawson-Roberts. She is an Assistant Vice President of Shared Services and Canadian Disability and Group Life at Manulife. Welcome, Corey. This really does feel like a talk show. I'm here for it. Janet Coe, the President and Co-founder of the Menopause Foundation of Canada. Welcome, Janet. Next, we have Dr. Sheila Ujay-Singha. She's a family doctor at St. Michael's Hospital and the Medical Director of Primary Care Outreach at the Women's College Hospital. Welcome, Dr. Sheila. And lastly, but importantly, we have a virtual panelist as well out in Victoria, BC, Dr. Kelsey Mills, joining us from Victoria. And Dr. Mills is an associate professor at the University of British Columbia, an affiliate associate professor at the University of Victoria. She's really accomplished, so we're still going. She is also a certified menopause practitioner, a board member of the Canadian Menopause Society, as well as Canadian Women in Medicine. Welcome, Dr. Mills. Thank you so much. So wonderful to see you all here. So let's just dive on in, and I'll start by setting the stage a bit, and this question will be for Dr. Sheila and Kelsey and Victoria, and it's going to be about just defining what is perimenopause and menopause and the symptoms and health challenges that people might experience at this, with these changes physically, mentally, and emotionally. So I'll start off by asking you, Dr. Mills.
Thanks, and I think that's a great place to start. When we think about defining menopause and perimenopause, first of all, I think it's important to acknowledge that that can look differently for many different people. When we think about classical definitions, somebody is menopausal when we look backward in time and they haven't had a period for 1 year. There are lots of different reasons why people enter menopause. Most people enter spontaneously, where the ovaries over time stop ovulating and producing as much hormone as they did before. But there are, of course, other reasons, like people who are going through chemotherapy, receive radiation to the body, have surgery to the ovaries. So people can enter menopause like that as well. And when we think about a definition of perimenopause, this is a little bit more amorphous. And we are only very recently starting to have more of a conversation about the transition in the midlife. But most people can start to experience symptoms 4 to 8 years before their periods stop on their own. And we can start to notice all sorts of changes, like vasomotor symptoms like hot flashes and night sweats, palpitations, new onset joint pain, vaginal dryness, decrease in sex drive, bladder concerns, weight gain. There are all sorts of changes that can happen.
Sounds like a treat.
It's really delightful.
Yeah. So Dr. Vijay Singh, I'd just like to get you to jump in as well.
Sure. So one of the areas that we focus on at work at St. Mike's and at Women's College is really looking at how different people experience menopause as well. And we know that despite biology being very similar in terms of the process that happens, the menopause and perimenopause experience varies greatly by culture, ethnicity, and specifically we know that different populations will have a different experience based on these factors. Specifically, we know that Black women and Indigenous women will enter menopause earlier than their white counterparts. They will also experience more severe symptoms and a longer duration of symptoms as well. And so hot flashes tend to last longer. They can be more severe. But despite having this difference in the duration and the severity of symptoms, these populations struggle to access care. And that is not a population issue or a patient issue. That's really related to our healthcare system, which is not safe for all patients. And that's something that we're working on changing. We also know that while there is research being done and there's a lot of excitement around menopause, there's limitations in the populations that are being studied. And so for my gender diverse and trans patients, when I'm working with them in the clinic, I don't have any guidelines that help me know what to do when they're experiencing symptoms. So I'm sort of doing it one-on-one, figuring it out. It's very nuanced, but these are areas that are really big gaps in menopause care. So addressing the ethnocultural differences, understanding how racism within our healthcare system plays a role in how people access care, and making changes towards shifting how we practice to make sure that healthcare spaces are safe, are critical to allow everyone to feel welcome, safe, and cared for within our healthcare system when it comes to perimenopause and menopause, in all aspects of medicine, really.
Thank you so much. And then Corey and Janet, wanted to pivot to perhaps looking at the realm of work, specifically some of the challenges that women and gender diverse people may experience in the realm of the workplace and how this may also have impacts on their careers. So I'll get Corey to go first.
Okay, thank you. And before I start, I just want to, on behalf of Manulife, a gold sponsor of this event, thank everyone for being here on a Friday afternoon in downtown Toronto, no less, so for a very important topic. I do recognize that for people in the room and for the many people attending virtually, there might be a different level of understanding and education around our workplace. So I'll just give a couple of baseline stats and then get into the question. So when you look at the Canadian population, 48% of the working population are women. Women over 40 represent 25% of that working population and are the fastest growing cohort in the workplace, which I think is fascinating. Why that's so important is when you think about those menopause years, women are climbing the corporate ladder, They are running businesses. They may be leaders in organizations. They may be individual contributors in those organizations. But they're also very likely juggling home care responsibilities, being the primary caregiver. They may also be dealing with aging parents. So they are doing a juggling act. And they're not always balancing that well. Then when you add in menopause to that, women deal with things like, you've heard some of the symptoms already, but how it impacts the workforce. So women are showing up to work not themselves. They're not 100%. And so what that looks like in the workplace is increased absenteeism, increased presenteeism. So women are at work, but not themselves, not fully engaged. Increased sick leave, increased disability leave. Women may be looking for part-time work, working more from home. They may also be looking at stepping out or down from roles. So big impacts to women in the workforce. And clearly it's to women directly, but when you think about employers, society, the economy, that's a huge impact at a macro level as well.
I'll just get you to jump in, Janet.
Well, I think we have to see this as actually a really exciting opportunity. We've never had so many women in midlife making such a significant contribution in the paid economy.
Here. Let's get some, let's give ourselves a round of applause here.
So I just see this as a tremendous opportunity to, for the very first time, consider the midlife women. We have been ignored, not deliberately. We've just never considered this stage of life. So there's no blame on an employer, on the healthcare professionals. But now that we know what we know, it's time for us to take action. Because there is 1/4 of the workforce female over the age of 40. And menopause does intersect with this critical career stage where we are assuming greater leadership roles. And the challenge for women today is that we are being denied access to menopause care and treatment. We've been misled to think that menopause is just this natural stage of life, and it isn't a disease, but it can come along with 30+ symptoms. It is a significant health transition, and it can last for a very long time. Perimenopause can begin in your 30s and last for a decade before you actually have that last period. So rather than looking at this as a negative, this is just our time to step up and to recognize that we have ignored women who are leaders, matriarchs in their family, leaders in their community, and incredibly important to the workforce. And I'll just give one more stat, because our landmark research at the Menopause Foundation of Canada, which for the first time quantified the economic impact of these unmanaged symptoms at $3.5 billion annually. So we need to pay attention and we need to take action.
Can I just jump in to ask you a bit of a follow-up, because I think that's such a great perspective to talk about, looking at the opportunities here too. And so I'm wondering if you have kind of the tension there of both the opportunities but the barriers that exist. How do we go about breaking down those barriers to better support women and gender diverse people at this particular moment in their lives?
Well, I think when we look at the workplace, there shouldn't be any barriers. So it's not a heavy lift to make a very significant difference. Organizations have always had a talent management process. Companies are always looking to achieve high performance. You've just never considered the midlife working woman. So look at your benefits, look at your programs, your policies. Breaking the taboo of menopause at work is the single biggest thing an employer can do. Every employer wants to create a high trust environment. You're not there to solve an individual's health challenges, but you do want a high trust environment where if I'm an employee and I have a barrier to achieving full performance, maybe I have some brain fog, maybe I want to start using an AI note taker. These are very simple things that organizations can do. When it comes to the healthcare system, this is the bigger challenge. The healthcare system is a big opportunity because we don't have providers who are trained and educated like Dr. Sheila, like Dr. Mills, who are really providing outstanding support. So it's time for us, from a healthcare perspective, make sure that our healthcare providers are educated, have the confidence to provide the treatment that they need. And by the way, they're not paid today to have that high quality conversation. It's not 5 minutes to talk to a woman about what's happening in midlife. Other jurisdictions are doing it. We need midlife women's health checks like they're doing in the UK, and we need more research for this stage of life.
I'm wondering, Dr. Wujah-Singha, if you wanted to jump in there about how to help patients get that assistance that they might need, perhaps maybe some of the treatments or strategies to help them navigate this transition.
Yeah, I mean, I think this is actually a really exciting time for us in healthcare because I was of the generation of doctors, so I graduated in 2004 from medical school. And we were taught in medical school, because of a landmark study that happened, the Women's Health Initiative, that overnight we should not be prescribing hormonal therapy because it was deemed to be unsafe. Now we have better information now, we've reanalyzed that, we recognize that the age of those who are being studied in that group, the average age was 63. So we missed all the women who were going through, like you said, Janet, like in their late 30s and onwards, for potential for intervention. And the exciting thing is that there are so many great options for treatment that it's exciting for me as a family doctor to be able to offer this toolkit to my patients. And there are really wonderful things that you can consider. We have great evidence for specific lifestyle interventions that are helpful in terms of dietary changes you can make, exercise changes that really help with some of those symptoms. We know that there are non-hormonal medication options that are exciting. That's a really exciting area because it's just new in Canada too, and this is where for those who can't take hormonal therapy, there are great options as well. And then there's hormonal therapy that, again, I was nervous to prescribe this as a provider. I had to unlearn what I was taught in medical school and residency to be able to do that. And now it's one of the most wonderful things that I can do is to be able to provide non-hormonal, hormonal options to patients because I know my patients so well. I've seen how they've shifted. They've lost their potential in terms of they don't recognize themselves, they're not functioning at work, their relationships are struggling, and I have an opportunity as their clinician to shift that trajectory for them. And so there are so many great options available. We just have to talk about it, share it, and implement it, and really teach the future clinicians of our society. I just taught 30 residents a couple weeks ago a 4-hour lecture on menopause, and they were super excited to do this work. That's 30 new family doctors who are going to be coming out in the next year who are ready to do primary care related menopause support. We just created a tool with the Centre for Effective Practice at University of Toronto that I had the opportunity to work with their team. It just came out last week. I suggest it to everyone when I speak about it because patients can download this tool. It's a tool that's created by doctors, for doctors, by nurse practitioners, for nurse practitioners to do this care. And it has great medication tables on it. It tells you what the costs of medications are. Patients can download this. If you have a family doctor, you can take it into your doctor to share with them if they're not comfortable. And we also offer training for clinicians to do this work. And last week it came out, and we already have 120 family doctors across Ontario who signed up to do this work and to get that extra training. So we are making headway in getting access to care improvements, but we still need to address that many folks aren't getting that care still.
Wow. Dr. Mills, I'm just wondering in this vein about supporting patients in this chapter. How do you see the efforts to better support them and perhaps some of the inroads that are being made that Dr. Wujah-Singha just highlighted?
I think that it is, I want to echo what Janet said. I think this is really an opportunity in this current moment where we have never had as many options for treatment, as much interest as there has been historically. But I think one of the foundational issues, especially where I practice in British Columbia, but across the nation, is that there are just quite simply huge numbers of our Canadian women who do not have access to high quality primary care through a family physician or a nurse practitioner. And primary care is really the foundation of our healthcare system. And so what I hear frequently And I would tell you 50% of the people that are referred to me do not have a primary care provider. So what I hear frequently is, I've waited years for somebody to help me, and I don't have anybody who can help me. So I think it's incredible if you have a primary care provider that you can start to have that conversation, or bring resources to talk about with your provider. And the Menopause Foundation of Canada actually has some amazing resources on questions to ask your provider, resources to talk about together, resources for a spouse who's supporting a person going through menopause, which has for the longest time just been ignored, and spouses and partners really want to have information and be able to support their partners as well. So the MFC has tons of resources around this, but one of the hugest barriers are people who are floating around out there, totally unanchored in the healthcare system, extremely symptomatic, and they are looking for help, and it can be very challenging to have a referral to somebody to even have the conversation.
Well, thank you, Dr. Mills. I think that provides a great segue to what I wanted to ask about next, because again, we have recognized today there certainly is work to be done and gaps that remain with respect to care. And so I'm wondering, where can health systems, policymakers, employers do more to support Canadian women in perimenopause and menopause? I'll start with you, Corey.
Okay, and I think I'll take it from the employer perspective. And I will say at Manulife, we work with a lot of employers across Canada. And employers are really, really interested in this topic. Women's health, from fertility, family planning that we heard about earlier, right through to menopause. They really do care about their employees, and they want to find ways to help them. So I will say from an employer perspective, I don't think the gaps are enormous. I think there are a lot of things that employers already have in their toolkit that they can use. But like any other workplace strategy, it really does start with education and awareness. We do know that a lot of individuals don't know a lot about menopause, including women. A lot of women go into menopause not knowing what's going on. So that is a really good place to start in terms of, bringing in speakers. There are a lot of fabulous tools that Janet and team have created. They are free tools. Menopause Works Here. There are symptom trackers. So, individuals educating themselves, certainly, but employers can play a big part in that. We know that 1/4 of women hide their symptoms at work. 2/3 of women are not comfortable talking about menopausal symptoms with their leader. We know that women step out of the workforce because of unmanaged symptoms. So employers really have not just an obligation, but I think a willingness to step up here to support their employees during that menopause transition. And so once we kind of get past education and awareness, I think like any other strategy, having senior leader buy-in is enormous. When you think about all the inroads we've made with mental illness over the years, senior leader buy-in, championing that cause is huge. Employees look at those people and say, they've been through it, they've conquered it, they're just like me. That is really, really powerful. So senior leader buy-in, having employee networks talking about this. Then from the employee awareness and education, the next tier is really look at your HR policies. Do they support a menopausal inclusive workplace? Do women have the flexibility if they've had a really bad night, they've not slept? I've been there many times. Can they come in a little later? Can they work from home when they've had a particularly bad couple of days with menopause symptoms? Temperature-controlled environments. We get hot flashes. And when you see women taking off their suit jackets at work, that's why. I have a fan sitting on my desk all the time. And for any of you who work in environments that have uniforms, have women been consulted in the fabric and the design of uniforms? So that's the next tier. And then the last tier is really about benefit offerings. When you think about HRT, we have seen a 43% increase in HRT claims in the last couple of years for women aged 45 to 54, and a 21% increase for women over 55. That is a really good thing, because 10 years ago we couldn't have said that, and Sheila spoke about that. So it's a really wonderful thing to see that women are getting educated about menopause, they're talking to their healthcare providers about menopause, and they are submitting claims for menopause, which we really want to see. Virtual healthcare is another. 6 million Canadians do not have access, Kelsey spoke to it, do not have access to a primary care physician. Mental health supports. Women do suffer from anxiety and depression when going through menopause. And so having those mental health supports, cognitive behavioral therapy, having coverage for that is wonderful. So there are lots of benefits out there today that you may not know as employers actually support women in menopause. So making that known to women and providing that education and support. Like Janet said, it's not a big lift. You probably already have it there. It probably just needs a couple of tweaks.
I'll get you to jump in, Janet. What would your message be to those policymakers? Maybe some of them are connected to folks in the room that have some levers. What would your main message to them be?
Well, I just want to say thank you first for what you just said, because honestly, 2 years ago, we would not have had leading employers talking about menopause inclusivity and just speaking so clearly about the things that organizations can do to make a big difference. So in terms of progress, that is tremendous progress in Canada. And Canada really has an opportunity to lead the world in creating menopause inclusive workplaces and to showcase how you can do that. So I'm very excited because we see that the work we're doing makes a big difference. In terms of the biggest stumbling block in Canada, it is access to menopause care and treatment. We have millions of women today who are being denied access to this care. Not every woman will get pregnant, but every woman, if she lives long enough, will experience menopause. It is not right that women are cycling through multiple doctors, desperately trying to get help. And then the other reality today is that filling the gap are virtual and private clinics. These are important new opportunities for women, but many of these are pay for play. So we should not have a two-tier system where women with money have access to care and women who do not have that do not have access to care. So we need everyone who touches midlife women in healthcare to step up. Get the training and the education you need. If you are running a walk-in clinic, that's where a lot of women go, to a walk-in clinic because they don't have a family physician that they can go to. So make sure you're up to speed on the latest clinical practice guidelines. There's no mystery about it. There's great alignment. All of the international societies related to menopause agree on how to treat women. And then we have to look at the systemic barriers to why this is happening. We need to make sure that our healthcare providers are adequately compensated to do this work. We also need to expand the scope of practice for people like pharmacists so they can start prescribing. We need to remove the black box warning on vaginal estrogen products. Genitourinary syndrome of menopause is a big thing. What about a women's health strategy in Canada that would include menopause, right? So there are big things that we can do, but we shouldn't see these as a barrier because I can tell you the cost to the healthcare system is enormous. Women going to multiple doctors, getting unnecessary tests, and taking unnecessary medication that doesn't deal with the underlying issues they are experiencing. The savings could be enormous if we just said we're going to prioritize women's midlife health.
I'm wondering, Dr. Sheila, if you have a main message to those policymakers or see kind of, again, levers perhaps in the realm of medicine that might be able to be pulled in order to advance care for patients. I think you highlighted some of the really positive, like the tool you mentioned, which I didn't even know existed. Yeah. So it's that's fantastic. But I'm wondering if there are other kind of areas for growth, if you will.
For sure. I mean, I have a whole wish list if I.
I want to hear it.
So I appreciate everything that you both said because I feel like it's very aligned where we want to do better for our patients, and it's a matter of like we're limited in certain ways. And so certainly for policymakers, I think we need a national pharmacare plan that covers medications for everybody. And that's where, BC is leading the way with that. Manitoba has their coverage for menopause hormonal therapy, but the rest of the country does not. And so I can prescribe these medications, but if my patients aren't able to afford them, that's not helpful to them. So we need to think about that. We need to ensure that there's billing codes specifically to compensate for this work, because that is challenging for family doctors who are already overstretched to do this work if we're not compensated for that. We don't talk about that very much. That's a big limiting factor for people to do this work, so I appreciate you mentioning that, Janet. We also need to look at medical schools. Less than 50% of medical schools actually have menopause on their curriculum at this time, and so we need to shift that as well, because the only way we will shift education and knowledge and comfort in prescribing will be in addressing that. And we do have to safeguard our public healthcare system. It is one of our gems in Canada. And right now, private healthcare is coming into the menopause space because there is a menopause gold rush right now. But they're filling a gap because we haven't done a great job of supporting our patients. And so the private virtual clinics are coming in and providing care, which is still something at least, but we still can't just say, okay, well, you can get it privately. We're not going to focus on it in the public system. We have to make sure that there are publicly funded options available for our patients to access, because getting menopause care should not depend upon your postal code. It should not depend upon your income. And these are things that are fundamental to our public healthcare system being safeguarded. At Women's College Hospital, we are starting a self-referral program to allow people who do not have a family doctor or a nurse practitioner to be able to self-refer into care in 2026 for menopause care specifically. And so these are some of the changes. There are really exciting things, but we do need the support of policymakers. And if I may, for one piece for employers, when I'm working with my patients and I'm writing them notes and helping them kind of navigate their symptoms at work, one of the things that I've noticed is that some of my patients, despite having coverage, it's different depending on what level they work at in their company. And so employers, please take a look to see, is it your executive level folks? Is it your managers who have coverage? But what about your frontline staff? They also need to be considered with insurance coverage to make sure their medications are covered, their access to pelvic floor physio, to psychology support. All of those things are also included across the board for all your employees, not just the managerial and above levels as well.
And Dr. Mills, I don't know if you have a wish list, but wondering if you might have some messages as well.
I just want to, I would echo everything that's been said on the panel so far, but I think it's also really an interesting opportunity to consider the positivity around this. I think as a menopause specialist and as somebody who sees people in my office every day with these symptoms, I think there's a lot of sense of challenge and consternation and frustration, but I think there's very much an opportunity here. I've never before seen people acting as such incredible self-advocates of patients accessing information to arm themselves with, what treatments are available to them, what lifestyle changes they could be making. There is so much information and ease of access to information. I think for sure one of the challenges can be, where do I find the good information and how do I weed out, social media advice versus evidence-based advice. But I just want the room and the virtual listeners to consider the positivity of this time in the midlife. Women are at the top of their game. They are achieving professionally. They've built incredible, families or companies or, and so now to kind of lean into this time as self-advocates, pursuing, your peak health. I think it's an amazing time. And I just, Janet always talks very positively about this time in the midlife. And I just want the listeners and the viewers to take away that as well.
And I did want to touch on that optimism, which I think is a really important message. And so maybe I'll do another go around. Corey, what are you optimistic about?
I think there's a lot to be optimistic about. One, the fact that we're all sitting here today talking about menopause. This wouldn't have happened 5 years ago. So I think the fact that we're having the conversation, people are educating themselves. Kelsey, I'm so glad to hear that, people are coming in and advocating for themselves, because again, 5 years ago, I started the menopause journey about 8 years ago. I have 3 older sisters. I was lucky to learn from them and see what they were going through, so it wasn't a complete surprise to me, but I have a lot of friends who it was a complete surprise to, and they really didn't know where to start. And the only avenue they had was their doctor. So it's wonderful now that there's a lot more advocates in the system around, talking about menopause. So I'm very optimistic about that. The other thing I'm optimistic about is when you think about mental illness, which is another passion of mine and has been for about 20 years, is 20 years ago, we started talking about bringing mental illness out of the shadows. There's actually, papers written about bringing it out of the shadows. And when you think about the language and how we talked about mental illness 20 years ago, when we think about menopause, there's still some of that language out there, right? And my hope is, as far as we've come with mental illness, we don't use the same vocabulary from 20 years ago that we use today, which is wonderful. I hope the same for menopause, that we will get to a point where women feel very comfortable, regardless of who they're sitting in front of, be it their boss, co-workers, clients, whomever, and they have a hot flash, they actually talk about it. I remember the first time I had a hot flash, it was during a presentation to very senior management, and there was only one other female in the room, and all the men got very uncomfortable because I said I had a hot flash. And they said, "Oh, we thought you were embarrassed because you didn't know the answer." And I was like, 1, no, I'm not embarrassed, and 2, I know the answer, but 3, I'm having a hot flash. So we also have to equip our men with how to respond in these situations too, at home and in the workplace. So I am optimistic about how far we've come and how we will talk about menopause. And the last thing I'm going to say on this in terms of optimism is, when I look at our disability data, so this is where I live and play, from 9 to 5, the number one reason women go off work and on disability is due to mental health disorders, anxiety first, depression second. The average age they go off work because of mental illness is 47. And when you think about that, there are a lot of women who work wounded. They don't get the support they need. And I think because we're talking about menopause, it's also going to open up the discussion around mental illness because of anxiety and depression, and they're going to get the help they need. So up until now, they've really been working wounded, almost with an arm tied behind their back, if you will, when it comes to menopause. And I think with all of this discussion and education and awareness, we're going to see more people going to their physicians and getting help for menopause as well as mental health disorders.
Wow. Janet, I know you have a lot of optimism. So what else are you hopeful about?
Well, I love the conversation about dialogue, because I think, historically, menopause in our society has been viewed through a negative lens. So the image of the woman in menopause is very unflattering, which is one of the reasons why I think so many women have avoided being associated with the conversation. So it's really our great opportunity to challenge the ageism that disproportionately has a negative impact on women as they get older, and to really change that conversation. Menopause should be celebrated. It's a really exciting stage of life, and we see more and more role models, examples of people doing really exciting things, and we need to honor that and change the conversation. When you see menopause as a stage of health transition, hopefully that makes you not trivialize some of the symptoms that women are experiencing. Hot flashes have been so trivialized. I think it makes women think that they don't need to do anything about it. But more and more research suggests that this is not something that is trivial. So we need to challenge our own biases against women as they get older, and also not diminish their health experiences, and recognize that it's an important stage of life to prioritize a woman's health, and to make sure that we're seeing her thrive in what is, I like to say, the prime of her life. So it's a really, really exciting opportunity to change the conversation around menopause.
Well, thank you, Janet. I commend you for truly for the optimism that you've been sharing with the room today. And I'll just get our doctors. We have a few minutes left here, but I'm wondering, Dr. Sheila, what you're particularly hopeful about as you look at the future.
Yeah, I mean, I'm very optimistic around this because I feel like it's given us an opportunity to change things, and the healthcare system is following the public demand to make things better, and it's really exciting. And I think that for me, in the 20 years I've practiced, this is like one of the most important parts of my career so far, is to be able to see this. I want to share a little story so this morning I was in clinic we started an Indigenous menopause women's outreach clinic for menopause care in Regent Park here in Toronto through Women's College. And we co-designed that with elders in the community. And it's this beautiful program where I recognized and I learned that actually menopause is not medicalized within Indigenous culture in the same way that we medicalize it in our general population. And it's seen as a time of aging well. It is a time of wisdom. It is a time where you are wise because you've gone through a lot in your life and you are leaders in your community. And I think that's something that I think we need to recognize, because we tend to pathologize aging. And as you said so beautifully, Janet, like this is an opportunity for us to really own this time in our lives because we have gone through a lot. It's kind of our I can't swear, but like no F's era, right? Like we've gone through a lot. It's okay. We can speak up for ourselves. We are not tolerating things that don't serve us anymore. And we can help you in the healthcare system if you're not feeling well, because we have great options available to help get you there. You know, when I shared this at a talk that we did together, Janet, but when I went through puberty, so menopause is basically puberty in reverse. My family background is Sri Lankan. When girls get their period, they get a lot of gold. So people come and they bring you gold bracelets and bring you gold necklaces. And I remember hiding in my room and being mortified that I didn't want any of this gold. But I'm like, I should be getting the gold now in perimenopause because this is the time to celebrate, right? Like I've lived through a lot. I've gone through fertility issues. I've had all of these things. I want a menopause party just like the egg freezing party because, again, this is a time to really embrace. We're all going to reach there. There's no reason why we can't thrive at this time. And I'm very, very optimistic for the future of Canadians because there's a change coming that it's happening right now.
I love what you just said, and I loved how many faces lit up, and they're like, me too, I would like some gold right now too. I'll just, Dr. Mills, get you to jump in with some final thoughts here.
I think if I was going to leave this audience with one thought, it's that women in the midlife deserve to feel well. And so if you are somebody who is having severe hot flashes, has noted that, intercourse and intimacy is now really painful or uncomfortable, or your bladder isn't working, or you cannot sleep, you deserve to feel better. These are not things that you need to suffer in silence about. There is help available. You can be an advocate for your own health and well-being. And so many of these things are actually, the treatment is not that challenging or not that difficult. And so I really do want to leave the audience with the idea that in the modern time, in 2025, in Canada, Canadian women deserve good health and deserve to feel well.
Yeah, let's give it a Well, this has been a really wonderful conversation. Thank you so much for being here today. And I think before we head into a 15-minute networking break, again, I'd just like to thank you for your insights, for your expertise, for your passion. Janet, I can feel your passion from here. It's honestly, it's sometimes in the work that we do as journalists, optimism isn't always something we think about all the time. We do try to find those solutions-based stories, but I've heard so many during this conversation. So I do appreciate that lens on the dialogue as well. So thank you so much for all the work that you're doing to help women and gender diverse people, to help them to feel well at this stage of life. So cheers to you, and let's give our panelists another round of applause. Okay, and so we'll see you at the networking break. Cheers, everyone.
All right, welcome back, everyone. We're going to begin in a sec. If we could find our way back to our seats. All right, welcome back, everyone. We're about to begin our next panel discussion, which will explore equity in care, specifically how we can improve access to health care across socioeconomic lines. Immediately following this panel, we'll hear a keynote address from the Honourable Marjorie Michel, Minister of Health, followed by a fireside chat. And to close out the afternoon, we invite you to stay and join us for the networking reception. All right, let's get rolling with this next panel discussion. The experiences of women navigating Canada's healthcare systems can differ significantly based on socioeconomic status and race. How can healthcare providers, community, and patient leaders close these gaps in knowledge and access to care? I am pleased to introduce three people that will help us explore these questions. Begin with Dr. Chika Stacy Oriwa, physician, expert in human connection, the neuroscience of leadership and innovation, and organizational wellness. Welcome, Dr. Oriwa. Next, we have Dr. Elisa Levi, a family physician, Nungwa Wellness. She is the founder of Nungwa Wellness, an emerging Indigenous-led primary care and healing space rooted in place, culture, and community. Welcome, Dr. Levi. And Jen Quinlan is CEO of Flemington Health Centre. As a leading provider of integrated primary health care in Ontario, the centre works to address unjust health outcomes by providing accessible services to vulnerable populations and advocating for policies that address the social determinants of health. Welcome, Jen. All right. All right, let's dive in. So for our first question, ask it for everybody. Women navigating Canada's healthcare system can run into roadblocks or gaps in care, and their experiences can often get even more difficult, depending on socioeconomic status and race. All three of you work in different areas of our healthcare system. So we want to go one by one. If you could tell us about some of the gaps that you see in where you work. Maybe, Jen, we could begin with you.
Sure. Thanks so much for having me. Good afternoon, everyone. Really excited to be following some incredible panelists. Thanks to those who spoke before us. In terms of the experience in Toronto in community health right now, I would say while I was optimistic about some of the pieces that our colleagues shared, I do think there's a layering impact and effect that maybe we're going to dive into a little bit on this panel. So of course, we want to be able to address perimenopause, menopause, fertility, and women's health issues broadly. But if you are in Toronto right now, those issues are not experienced the same depending on your race, class, income, gender, and sexual orientation. And so I think it's really important for us to unpack some of those pieces. At Flemington Health Centre, where I work, and I have the privilege of supporting about 20,000 clients in our organization, we're really focused on making sure that we think about the social determinants of health and make programs that address those so that everyone has access and equal opportunity to good health outcomes. So in terms of some of the things that I think we might want to talk about on this panel and some of the issues that are facing us today, there's a lot of, I think, pullback from health equity at this point in time, from our policies, from funding, from the ways in which our organizations are being asked to run programs and services. And I think with the conversation around women's health, if you layer on health equity, we're in a bit of a precarious time. And so some of the things that I want us to talk about today would be some of those gaps, but also some of the solutions. So in terms of gaps, right now in Thorncliffe Park, one of the neighborhoods that I work in, we have actually the highest birth rate in Toronto. So it's 76% higher than the average in the city. So lots of young families. We have a huge kindergarten. If you come down at 3 p.m. into the neighborhood, it's total chaos, but in a great way. And when I think about the health needs of the women in the neighborhood, it's usually that the folks are putting their own health last. So they're prioritizing their kids' health, they're prioritizing their family's health, they're dealing with, as an earlier speaker talked about, multi-generational sort of caregiving, and mostly doing it as newcomers without their support system in place. And so I think we're facing a bit of an uphill battle right now in terms of the social determinants of health, and I think it's a concerning time to be trying to address those.
And Dr. Levi, what are you seeing in your community?
Thank you. Thanks for the introduction and the invitation to be here, and to the other panelists who did speak a little bit about inequities in the first two panels. So I am here today bringing a perspective. I practice in rural Ontario, about 3 hours north of here on the traditional territory of the Saugeen Ojibwe Nation. I'm a family physician, and as mentioned, have started a new primary health care team, Indigenous primary health care team within the community. So this is a community. This is a community of 800, and I think it was also mentioned that across Canada, many of people do not have access to health care. So this would be the first time that a rural community would have access to primary health care permanently, right? So I'm currently the physician providing services there. I think about when it comes to gaps, there's an important thing to recognize in Indigenous health, that gaps must be recognized and trust must be recognized in the history of Indigenous people, especially for women. So there's many reports, and I hope you have read the Truth and Reconciliation Calls to Action, Missing and Murdered Indigenous Women. So I am an Indigenous physician, and I have read those documents, and I know those truths. So when I see somebody, I know, especially because I work with a very small population of First Nations people, that I know that they have and may have been faced with, or know somebody who's been faced with forced sterilization in our country. And I know up until 2020 that they may have been feared birth alerts during pregnancy. But I don't come forward with that. I know that, and it is our responsibility as care providers in workforce also to know the barriers that individuals face, especially populations such as Indigenous peoples in our country. But I go with what are the opportunities, what are the points of connections through transitions. It's a beautiful time when you transition into puberty to prenatal health, and as was discussed in the earliest panel, through menopause. So what are those points of connection, and what are the opportunities that I can connect with the person to provide care? One gap I will talk about is non-insured health benefits. So sometimes people or providers aren't aware of the benefits that people can access. As well as on the individual side, what are some of the benefits that they can access? So creating more information to know, because right now for fertility, just as my last example, if you were to go on their website, it'll say in certain exceptions are made, but that's as far as it says. So we have to be more open about pathways for health, and that's a gap that we can continue to talk about this afternoon.
Yeah, I mean, those benefits aren't very helpful if people can't access them.
If you don't know, definitely.
Yeah. And Dr. Ariwa, what have you seen in your work?
So again, thank you so much for the introduction and for the opportunity to sit here with these incredible panelists and be able to share my view specifically from the world of psychiatry. So I'm actually still in my psychiatric training in my residency. And so I'm speaking from the perspective of even this recency of being with patients throughout my experience so far in my training, and also looking through the perspective, particularly as it speaks to inequity, of Black women, because I myself am a Black woman, and going through medical school and doing a lot of advocacy around that, and then seeing how that intersects with mental health within the Black community as it pertains to women. So I think we can all appreciate that mental health, especially during points of transition for women, is something that is not often spoken about. So we tend to really fixate or focus a lot on the physical kind of ailments or the physical symptoms that can arise with menopause, or the physical challenges that can especially arise with fertility challenges. But oftentimes that discussion around how the mental health impacts of, say, if someone is struggling with fertility, or the postpartum implications on one's mental health, that some of these things might not always be directly addressed. But then that issue is further compounded when you kind of dissect it further into looking at different racial groups as well. And I think one point that was particularly pertinent that I recently thought of was that there was a study that came out of Women's College Hospital fairly recently, I believe it was last year. It was from a reproductive psychiatrist, Dr. Clark, I believe, and she looked at the disparities between Black women and other non-racialized groups as it pertained to their mental health experiences postpartum, and found that Black women, in fact, experience significantly more symptoms of postpartum depression and a greater degree of severity as well as also, interestingly, experiencing more cases of bipolar disorder in the postpartum period, as well as more birth trauma, which wouldn't necessarily be all that surprising if you think about the disparities within obstetrical care as it pertains to Black women, and symptoms not necessarily being addressed on time, or even the maternal mortality rate. So there's a lot to unpack there when it comes to some of the gaps that can be present. But I think even, currently I'm presently working on the inpatient unit at CAMH and seeing some of the sickest and most mentally individuals who are struggling the most with their mental illness in society coming into our care, and recognizing that one thing that has always struck me to be quite fascinating is that seeing the abundance more of Black women, particularly in the inpatient unit, as opposed to my outpatient rotations, and seeing that there just aren't as many Black patients in these settings. And that's something that has always come up in a point of conversation over my years of training, is that the access of care for Black women, especially experiencing a mental health episode, and such that they are more likely to get the care that they need when they're in crisis, as opposed to being in the community and then being picked up in the community and managed in the community. So there's a lot to unpack there.
Yeah, thank you. Well, we outlined some of the challenges, and I know you're all doing amazing work too in your community. So I'd love to hear about some of the work that you're doing and some of the successes maybe you're having in addressing these gaps. So again, maybe we can start with Jen.
Sure, happy to share some of the bright spots. So I mentioned earlier that the neighborhood that I work in has a very high birth rate and is full of wonderful, big, boisterous families. But at the same time, the ways in which you provide care have to have some sort of cultural sensitivity. And so that's what I want to tell the story about. So right now in Thorncliffe Park, we have a large wave of newcomer families coming from Afghanistan. Thorncliffe Park is one of those neighborhoods that kind of reflects the geopolitical landscape of the world. And so at this point, we have usually more than 100 families a month coming in seeking care. They're often women-headed families coming into the city, probably having left back a lot of their supports back home in Afghanistan, and often arriving with some young children. And so when coming to our clinic, Health Access Thorncliffe Park, we were struck by the fact that we were not creating a welcoming, trusting, supportive space, and folks were kind of coming maybe once to receive care, and then we were kind of losing them to follow up. Folks were not coming back. So we did some internal work. We looked what were some of the gaps, what were some of the experiences that our clients were having, and we noted that we had a big gap in our cultural competency serving Afghan communities. So we partner with the Afghan Women's Organization, a wonderful local community organization who has expertise in this area. We ended up hiring an Afghan support worker, Fatima. If you come to the Health Access Thorncliffe Park, basically Fatima's in the waiting room managing everything. Fatima's in charge of Health Access Thorncliffe Park. If she's sick one day, it's a real problem. And so, having Fatima come on board, she is our eyes and ears on the ground. She helps translate things for our physicians. One interesting story is in Canada, as someone rightfully said, primary care is aiming to be the foundation of the healthcare system. I think we're still getting the funding to make that a reality. But in lots of parts of the world, the specialist system is the foundation of the healthcare system. And so folks coming from Afghanistan actually think that we're not giving high quality care by not referring out to specialists. So these women would come and they would be looking for perinatal care, but they would always want an obstetrician. And so it was a conversation with Fatima to say, actually, this doctor is not holding you back from a referral. She's not giving you bad care. In fact, this is good care in Canada. This person will give you really good perinatal care. You're welcome to have an obstetrician, but there are barriers to having an obstetrician as well. In this clinic, you get interpretation, you get transit support, there's childcare when you come. So there's a lot of pieces around you that might actually be driving better care for you in this space. So even our clinicians knowing that they were being seen as gatekeepers to the Afghan community, and that conversation was creating a more open dialogue to say, you're actually getting good care. Fatima has also helped us create a women's support group, and so we have women coming together weekly who are supporting each other through their pregnancy. Maybe their mom is back home and that would be someone they would rely on for advice, so they'll be able to speak to other people in the neighborhood that come from similar cultural backgrounds. We have a lending program, so we have cell phones with data, because of course WhatsApp and connecting back home is really important, so that's one of the supports we put in place. We have a breast pump lending program. That's another area with a lactation consultant to help folks breastfeed in a very busy environment with their kids in school and other challenges. And then also we have a cooking program. We have a beautiful kitchen where we have folks come in and work with our dietitian to be able to learn about healthy eating in Canada using some of our local ingredients that folks are maybe a little bit less familiar with. So we learned all of that through community consultation, through listening to our clients, through challenging our own assumptions around what good care looked like, and basically from listening to Fatima. So I think we all need to kind of be humble in our work and looking at inequities through different lenses. Even if you've been in an organization for 20, 30, 40 years, even if you've been a physician for 20, 30, 40 years, each patient, each client, each community can teach us something. And so I think it's really important for us to stay humble and keep iterating, keep changing our programs, keep listening, and making sure that the services that we're offering on the ground are the ones that are meeting the needs, as opposed to sort of keeping everything at a surface, maybe everything at arm's length. So that's one example of a program at Health Access Thorncliffe Park that we're really proud of. And if you, are interested, we'd love to have you at the Thorncliffe Park Community Hub. We're really proud of the work we're doing.
Thank you. I think it's a great message for this topic and for everything else to keep challenging yourself and keep trying to grow as well. Dr. Levi, what would you like to speak about in your community?
Not specific to my community. So I am in my second year of practice as a physician. I went back to school and chose medicine as a second career. And did that with 2 young children. So I think women in the workforce, women in academia. Thank you. And so I am new to practice, but I have worked over 20 years in Indigenous health. So I'm just going to take it a bit more broader about some things that have really improved. So, and on our panel, we're talking across the spectrum. So for pregnancy, for Indigenous women, I think the statistic is around 200 kilometers that some women travel for their pregnancy and care. And that's far, that's away from their family, that's receiving care in places that they're not used to. That's not with their primary care provider. If they do have that, it may be with specialists. So some things that have improved across the country are access to Indigenous patient navigators in some hospitals and really building out those systems and creating programs within that, connecting cultural safety in the hospital. Certainly there are challenges and there are gaps and there's areas for improvement, but I think that is a great success because they can be found in many hospitals and in Toronto as well. Thinking locally as well, recommendation to increase Indigenous health professionals in Indigenous communities as well as traditional health. So if we think about midwifery as, for example, there's now funding for birth centers in communities, I think Six Nations as a good example, and providing training of those health professionals there. So there's both an opportunity to support these programs, fund these programs, I think at a government level, and as well in Toronto. I think when I was having my own children and lived in Toronto, it was the beginning of when seventh generation midwives had built out a clinic downtown, and they built it from the ground up, right? They really thought about those specific rooms within, how they would deliver care, how culture would be integrated. So those are examples, but what they really rely on, and I think for any population, including the population that you talked about, is the involvement of those who are being affected by the programs. That is the most successful or the most important thing that can be done if you're involved in programming. And then I think back to my own local experience. So in reimagining what healthcare experiences have been for people who have experienced harm. So say in a clinical examination room, how can we take that and step back a little bit and think about that experience and how do we involve people in that? And so that's something what I'm grappling right now because because it is a rural area, there isn't a place for me to lease and retrofit. I have to build we have to build, the organization has to build, and really take time to think about the healthcare experience.
You're building a brand new space?
Yeah, yeah.
How has that process been?
It's learning all along the way. The organization is at its very beginning, but really taking time to ask that question. Like, if we are doing Indigenous holistic healthcare, does it look like a traditional experience of walking in and having a service? Someone with a barrier there. I think involving people from community in that design has been the most eye-opening in terms of wanting to be involved in care and wanting to really experience on the land and have access to the land as part of the healthcare experience. So how one integrates that is, I guess, the next step. So it's something positive.
That's great, and an opportunity to not go with some of the old, to let go of some other traditions, perhaps in the practice.
Try to.
Dr. Uwa, what successes have you seen?
So I actually want to piggyback a little bit on what Dr. Levi said on this concept of ensuring that there is appropriate individuals in the community who are trained specifically to be able to meet the needs of that community. And I think that when it comes to Black mental health, specifically Black women's mental health, I like to take that kind of bird's eye view approach and seeing what can be done from an educational and institutional perspective. And because I only graduated from medical school five years ago, and so it's so fresh to me how it is that we are trained, especially within the world of psychiatry, to be able to formulate patients and look at certain things that can contribute to the manifestation of one's mental health concerns. And I recall, actually, just as a brief story, when I was in medical school, and I was doing my family medicine rotation, which I think is really important to kind of focus when we're thinking about mental health, to focus on family medicine, because they do the lion's share of mental health in the community, right? So it's like, absolutely, we're respecting the work that is done there. And that's also where a lot of the first catchment is when it comes to mental health diagnoses, to be actually, able to flag when a patient is presenting with concerns so that they can receive the appropriate diagnosis before they're even referred on to a psychiatry team. And I remember being in medical school and doing my rotation through Regent Park and encountering many more Black patients in that community than I would in other communities, and recognizing that the way that their mental health concerns would present in that context was very different. And also hearing from these patients quite often that, I didn't feel comfortable disclosing this to my original family doctor, but you as the med student, I was only in my third year, I'm more comfortable sharing these things with you because I feel like I can identify with you, or that you can understand certain things. And one of the things that kept coming up for my Black female patients was a concept of how their hair and their relationship with their hair connected back to their own mental and physical health. And that is something that, if you kind of understand the relationship between Black women and hair, and historically how it's been politicized, how it's been demonized. It's such a different and sacred relationship. And so being able to intimately understand that reflexively also enables that pathway for us to be able to discuss more around their mental health concerns. And so one of the things that I did in medical school was that I actually created a manual and a pamphlet and a handout specifically for Black patients as to how they can take care of their hair in a cost-effective way, because that was a huge issue within the community that wasn't addressed because they didn't have very many Black doctors there. And that continues to be an issue that, in fact, I'm still contending with my patients on the inpatient setting, my Black female patients. So when someone is there and we're trying to assess their clinical progress in the hospital, and my patient says to me on Monday, I don't feel comfortable tending to my hair, but then they tell me on Thursday, I did a whole wash day routine today. When I reflect that back to my staff, they're just kind of like, okay, well, that's great. But I'm like, no, but do you really understand how long it takes to really detangle and moisturize and sit with it and then braid it afterwards? Like, that is a 6-hour process for some of us. And that really can be reflective of one's own capacity to care for themselves. That is a clinical indication of progress. And so I think that part of the position or the role that I've played, especially, as a medical learner, and it's still in my training, is being able to translate a lot of that back to the other areas of our clinical team, but then also doing a lot of advocacy for how it is that we are able to conceptualize and really formulate mental health presentations within the Black community.
I think what's amazing about what you're saying, and in fact, I think with all your stories, is how important it is for, I guess, patients to see themselves in the healthcare providers, to be able to have that connection.
Yeah, it's really, really important, and especially, when I was going through medical school, I was the only Black medical student at U of T out of 260 students in my class. And so there have since been changes with the Black Student Application Program and significant changes with respect to equity in medical admission, such that there is more representation, at least from the Black community. And that is imperative because we run into these challenges, and we know that patients historically and based on research they will report having higher levels of satisfaction when they are able to be cared by someone with whom they identify. And so that it can lead to real, significant clinical implications in that regard. And so just being able to have more Black individuals, but then we also know that there aren't that many Black psychiatrists in general. Black female psychiatrists is even more niche. So being able to just increase the representation by having that critical mass is really important.
Oh, was there anybody else wanted to jump in on that?
Just to say that even in the experience of how we just have to challenge the way we do things. And I think in my current example of starting a practice, there's a regular intake, right? We do intakes, we've been trained on how to do intakes, and they usually start from, the same past medical history. And you can do that, and that's medicine. And so I've kind of readjusted and said, well, what if I ask first, and this could be for any male, female, first about their physical health, their mental health, their spiritual health, and have them start with a self-rating there. And I think there's a different conversation that comes up, right? Because you hear about what's important to them. Of course, you're going to do the medicine side, the preventative care and that, but I just challenge if you have the opportunity to just try to do things differently, I am noticing that the conversation changes.
All right, thanks very much. We have just a very short amount of time left. Any final words about what we've been talking about? Jen?
Sure. I think in terms of my perspective and maybe my call in to folks in the room would be, yes, it's great to have diversity and reflection of your race, class, gender in your medical team, but also I think all of us here have the opportunity to dig into being greater allies, to learn more about other cultures, to be able to connect with folks that don't look like us, and that actually will also strengthen the medical system in Toronto and Ontario. And so that would be my call in to folks in the room.
All right, thank you very much. Well, I think this was a really informative, insightful panel, and I really appreciate you being here with us today. I just want to thank our panelists, Dr. Chika Stacey Ariwa, Dr. Lisa Levi and Jen Quinlan. Thank you very much for joining us today.
Thank you very much.
All right, now I'd like to transition to our closing keynote. Very pleased to welcome the Honorable Marjorie Michel, Minister of Health, to the stage. And following her address, we'll have a fireside chat to continue the conversation and also have an opportunity for questions. So please welcome Minister Michel.
Good afternoon, everybody. Great to be here today. Almost 100 years ago, 5 women gathered in Alberta with a bold, revolutionary idea. Women are persons. 2 years later, in 1929, the Supreme Court validated this, granting women the right to vote in what is known as the person's case. We have come a long way. Since then, women's role within society, including healthcare, have boldly taken off. Les femmes sont médecins, infirmières, radiologues, dentistes, hygiénistes dentaires, psychiatres, thérapeutes, etc. Et les femmes travaillent dans les universités, les centres de recherche et les instituts médicaux. Aujourd'hui, je veux me concentrer sur 3 aspects. Les femmes comme patientes, les femmes comme professionnelles de la santé et les femmes comme chercheuses. First, women as patients. For too long, women's health was a blind spot in our healthcare system. Women weren't taken seriously when they sought medical help. Hysteria was the go-to word used to describe anything a woman could experience that a man couldn't. Mental health issues like postpartum depression were once treated with lobotomies. Social stigmas around fertility, childbirth, and menopause discourage women from getting help for their health. But even if our understanding of women's health has evolved, women remain disproportionately and differently affected by many healthcare issues. And because of a legacy of inequity, women's unique health needs continue to be misdiagnosed, misrepresented, and misunderstood. For example, we still struggle to understand perimenopause and menopause and its effects, and to combat the stigma surrounding it. Women are more likely to develop osteoporosis and suffer from migraines. During her lifetime, 1 woman out of 8 will receive a diagnosis of breast cancer. To improve how we create guidelines for preventive health care, like breast cancer screening, the Public Health Agency of Canada asked experts to review how the Canadian Task Force on Preventive Health Care works. And I have asked FAC to ensure the updated task force is fully ready to operate by April 2026. Des conditions comme l'endométriose, qui affectent environ 2 millions de Canadiennes, peuvent avoir un impact significatif sur leur vie. L'endométriose peut aussi avoir un impact sur la santé reproductive. Pour les femmes autochtones, les droits fondamentaux comme l'accès à des soins de santé respectueux, culturellement adaptés et sécuritaires sont souvent refusés. On pense bien sûr à Joyce Echaquan au Québec, mais elle n'est pas la seule. Last week, at the Aboriginal Friendship Center in Calgary, I met with Jerry, an Indigenous woman battling addiction. She told me the Friendship Center helped her feel truly seen for the first time in her life. She got the spot 3 years ago, and she is 75 years old. Our government proudly supports initiatives like the Calgary Friendship Center because mental health is health. Helping people manage addiction is health care because housing is also about health. And we know that Indigenous women, racialized, disabled women, and members of the 2S LGBTQI+ community are more likely to experience mental health issues and homelessness. N'oublions pas que même si nous avons de la chance au Canada, nous avons beaucoup de travail à faire pour garantir un accès sécuritaire aux services de santé essentiels. C'est particulièrement vrai dans les communautés rurales, éloignées et autochtones. Notre système de santé est public. C'est pourquoi notre nouveau gouvernement collabore avec les provinces et territoires pour s'assurer que les services médicaux sont fournis conformément à la loi canadienne sur la santé. C'est le cas, par exemple, pour les services d'avortement, un droit que nous ne devrions jamais tenir pour acquis. Let's now talk about women as healthcare professionals. Equally vital are the women caring for patients. Healthcare is one of Canada's fastest growing sectors, supporting 3.5 million jobs, about 15% of our labor force. Last month alone, 14,000 of the 60,000 new jobs created were in healthcare. Most healthcare workers are women, making up 79% of those 3.5 million jobs. 90% are nurses. Last week, I participated in a breakfast hosted by the Canadian Federation of Nurses Unions, where the theme was workplace violence. Nearly 60% of nurses experience some form of abuse or violence, verbal, physical, or harassment from patients, visitors, and unfortunately, even from colleagues. The work of nurses is often harsh and sometimes dangerous. We must work together to ensure they receive the safety and the recognition they deserve. Just yesterday, Jennifer Stinson from Sick Kids became the first nurse scientist to receive a Gardner's Foundation Award. This recognizes the immense contribution all nurses are bringing to our country. And nurses have an ally inside government in Canada's Chief Nursing Officer, Dr. Lee Chapman, a position we reinstated back in 2022, 10 years after being abolished. We are also seeing more women entering medical schools. Becoming a doctor is no longer an exclusive privilege for men. Today, 46% of new physicians are women, and by 2030, women are expected to comprise half of all doctors in Canada. Which is not surprising, since as mothers, sisters, daughters, women have always done more than their fair share of delivering care. But healthcare professionals in general often lack the time to provide the comprehensive care for every patient in need. We need more healthcare workers, and we can address this by ensuring that the significant number of internationally educated health professionals already here in Canada are integrated in working in health care. Past week, during the health ministers' meeting in Calgary, my provincial and territorial colleagues and I made several important commitments. First, to accelerate credential recognition so that foreign nurses and doctors can start working in the healthcare system faster. Second, to improve labor mobility through mutual license recognition models, allowing healthcare professionals to work anywhere across Canada and to better support underserved and Indigenous communities. Third, I committed to working closely with my colleague, the Minister of Immigration, to streamline the process for welcoming new healthcare professionals into Canada. Enfin, nous avons discuté des outils numériques et de la façon dont nous pouvons mieux équiper les professionnels de la santé grâce à la technologie. Let's now move to women as researchers. Earlier on, I spoke about how women are differently affected by many healthcare issues. Better healthcare for women begins with better research. In Canada, we believe in science. We value our researchers. For too long, research was conducted almost exclusively by men and often for men. We need more research made by and for women. Research is a valuable resource that helps clinicians make better treatment decisions, ultimately benefiting patients. Nous reconnaissons que les femmes font face à des défis de santé qui leur sont souvent uniques. C'est pourquoi le travail soutenu par l'Initiative nationale de recherche sur la santé des femmes des instituts de recherche en santé du Canada est si important. Cette initiative investit dans la recherche pour mieux comprendre les enjeux de santé qui touchent les femmes de manière disproportionnée ou différente. The research covers everything from diagnostics, therapeutics, and medical devices to healthcare implementation. For example, a team led by Dr. Tanya Direna at Women's College Hospital in Toronto is working on validating a screening measure for the early detection of endometriosis. In Canada, it often takes up to 5 years to diagnose endometriosis, largely due to low awareness among health workers, providers. There is a critical need to shorten the time between symptom onset and the diagnosis, and this is what this research aims to achieve. At UBC, Dr. Geraldine Pryor has been studying perimenopause for the past 30 years. With support from CIHR, she has been exploring ways to improve the symptoms of perimenopause. Her work has led to breakthrough and raised awareness about this often overlooked phase of women's health. To quote Dr. Pryor, at least now we are talking about it. These conversations are the first steps. women-led research teams are at the forefront of the development of innovative solutions, revolutionizing the health of women in Canada and across the globe. In the past year, we have been increasing funding for women-focused research, improving the collection of sex and gender-specific data, and implementing policies that improve care for reproductive and other women's health issues. Through CHHR, the Canadian government supports several knowledge mobilization hubs dedicated to maternal and perinatal health, including research on medications such as antidepressant, anti-seizure drugs, and pain relievers during pregnancy. These are just a few examples of initiatives supported by our government. Over the last 5 years, CHHR has invested more than $320 million in new research projects related to women's health. Research leads to innovation, better health, and prosperity. As Minister of Health, I'm extremely proud of the work CHHR and the thousands of researchers they support are doing. Together, we are deepening our understanding of women's health. En ce qui concerne la santé des femmes, les défis auxquels nous faisons face sont importants et complexes. Les stigmates culturels entourant la fertilité, la santé postpartum et la ménopause persistent. Sur ce sujet, la sensibilisation et la formation sont essentielles. Over recent decades, we've made real progress in advancing gender equality and women's rights, including sexual and reproductive rights. We know that in both personal and economic terms, the stakes are high, and so are public expectations. We must move forward, breaking down barriers, closing the gender gaps in research, and ensuring equitable health care for women. We cannot build Canada strong without healthy Canadian women. And let me remind you, we women are making more than half of the population. I want to thank everyone for their commitment to improving women's lives and health outcomes across Canada. And I want to thank all the healthcare professionals who are building our healthcare system stronger. Let's keep this important conversation going. And before I leave, I will put my hat to say, go, Jays, go! Thank you. Should I sit?
We can sit over here. All right. Well, thanks very much for that speech. That was wonderful. The first thing I wanted to ask you about was, digging into the workforce a little bit, because you mentioned that a few times when you were speaking. The issues around both people who are in the workforce, feeling burnt out, maybe not having enough support, making sure that we have enough people to provide the healthcare that people need. And also, in the panel before, we talked about the importance of diversity in staffing as well, just so people have proper healthcare outcomes. So as the federal Minister of Health, you have a lot of power on the healthcare system, but you don't have all the power. Health is a part of the country that's divvied up amongst a lot of jurisdictions. So I was wondering, on the workforce issue, can you kind of walk me through what you're able to do from Ottawa and what other parts of that file that you have to work with the provinces on?
Okay, so I will share with you how I see it. So first, as the federal minister, I have the power to convene. So I have a leadership role to play by bringing all my counterparts together to tackle the same issues, because everybody is living the same kind of challenges. And from a province to another, you can see difference, but everyone is having the same problem, not having enough people in the workforce on the healthcare side. So what we said, this is why I'm talking about foreign recognition credentials. They all agree that we have to move forward with that. And I, as a federal minister, I have to work closely with my colleague, the Minister of Labor, and and I already talked with her about this. And also the provinces have to talk with their labor minister also, so they can work closely with the federal to make it happen. Some provinces are more upfront than others, but what I can tell you across the country, every province, every territory, they know that now is the time. They know now is the time to look at the healthcare system differently. For sure, we have a lack of healthcare professionals. Everybody knows that. But how many doctors or nurses we will be able to bring into the system? Quite a number. But at the same time, we also have the technology coming in. And this morning, I was at Etobicoke Hospital, and they were showing me what, how AI is going to help them reduce the workload on their healthcare professional. And we can see it, so that doesn't mean that we will replace people by AI, not at all. But as you talked about the, people going into burnout, I think all those tools will help people having more time to work with their patients, to do the real work that they are called to do. So, but I would say, so I'm already on it, I think right now, what we definitely understand, we cannot act alone. Me as the Minister of Health, even within my government. When I'm telling you, for example, that I'm working with the immigration minister to see how we can be more professional, because I cannot do it. I have to constantly work with her. And also, I have to ask my counterpart, go to your immigration colleagues, because you have to define your priorities. If you don't come to my immigration minister with your priorities, we cannot do anything. We can talk all the time about streamlined processes, blah, 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 but we won't make anything happen in real. So my role is to push people working together, because definitely I think if we are not all, and not only ministers, I'm talking about organization, I'm talking about the healthcare professional, even the patients. If we are not all working together, the system will not improve, and the system will be more and more at risk. You spoke also about diversity in the workforce, and the need for people, to receive the care with, the culture. Agree. The healthcare professional workforce is starting to be very diverse. It's very important. But I would also say, and this is why in my speech I talked about raising awareness, training, and sharing information. Because let's say I'm a Black person, so I know for sure, maybe more with within the Black community. But that doesn't mean that somebody who comes from the Chinese community cannot work with the Black people also. But they need to know some specifics. So I think the system needs to be more fluid so people can learn from each other, because just again this morning when I was looking at the patient at the hospital in this neighborhood, you have so many different people, and as you know, you have also different diseases related to some population that sometimes we don't know. So I think this is how I feel we need to work again collaboratively and have diverse teams and share information so people can have better outcomes.
I think I have to ask, one of the things in this area that's come up very recently is Ontario, some of the changes that they've made for international medical graduates. Is that something that you've talked to your counterpart in Ontario about?
I didn't talk specifically with my counterpart in Ontario, but we talked most broadly at the FPT last week about this. I know, let me be clear. Some people, I'm in Ontario today, you are talking to me about the government of Ontario, and that's normal. I was in Alberta, they were talking to me about Alberta, and when I'm in Quebec, they are talking about Quebec. Right now, I really emphasize on collaborative work. As I told my partners, my role and my strong duty is to protect the Canada Health Act, because this country, until today, we chose a public health system. So my responsibility is to protect the public health system. But a part of this, they are trying different things because they don't have the same realities. The realities in Quebec is very different from the one in Ontario, but the good news I would tell you, when I had my FPT, what they said, we need to share best practices. So, and they ask us as the federal government to lead the best practices book that we will be sharing with them, because there's not one answer. And I think every province are facing challenges. I am not there to criticize my provincial counterpart. They are also elected people. And, they have to answer to their own population, as in my case. And I really feel that in the health system right now, everybody's trying with different philosophy. This is, diversity is our strength. We are different regions. When you go east, it's very different to go west, and I'm from Quebec, again different. So I think what I'm trying to say is we need to accept that people are trying different things, but as long as they are following to the Canada Health Act, and every time they will go out the Canada Health Act, I will have to stand up in front of them. This is the reality.
All right. And when you were referencing the FPT, that's the meeting of federal, provincial, and territorial health ministers. That was in Calgary the other week?
Yes, it was in Calgary the other week.
Well, maybe I can ask about, you mentioned the Canada Health Act, maybe I can ask about another piece of federal legislation, which is we just passed the 1-year anniversary for the passing of the Pharmacare Act. And, a key piece of that was to offer universal coverage, hopefully universal coverage for diabetes and contraceptives. Could you tell us kind of where that's at? Like, I know you have some, but not all provinces signed up.
So I will go back a little bit with you. When we put this program in place, we voted for Pharmacare. So you need to understand that we have legislation. So meaning that until somebody would remove the legislation or vote against it, the legislation is there. In the past government, they offered, as you said, for diabetes and contraceptive. 4 provinces moved forward with this program. They were ready to take it. A number of them wanted to have something else. They didn't want diabetes, or maybe it's contraceptive, or something completely different. It didn't sign under the Pharmacare program. Today, we are monitoring those 4 agreements to see how they are doing. And we are continuing conversation with provinces and territories about Pharmacare. As you know, we are in a very difficult context right now. but that doesn't mean it won't happen. I'm continuing conversation with each province and territories because at the end of the day, what do we want all? As a member of Ontario, you would like for the Ontario government to address, to help you in what is needed. Same for the Northwest Territory people and the Quebec. It's very different from a province to another, but for now, I'm continuing conversation with my counterparts, but today I don't have a new, agreement to sign because they are not there.
Right. And which are the 4 provinces so far?
It's BC, Yukon, Manitoba, and I think I have an East Coast. It's PI.
Yeah. Sorry, just for anybody who wasn't sure about which 4.
We don't have the big provinces, Ontario, Quebec, Alberta are not in it.
Mm-hmm.
And you need to understand, when the pharmacare passed, every provinces could raise their hand, but they were not there. They were not there at that point.
Right. It's still a bit of a work in progress.
Yes.
Great. Well, I think we're over time. Thank you very much for joining us here today.
Thank you.
All right. Thank you all for being part of today's important conversation. We've heard powerful insights about the gaps in women's health care and the systemic barriers that many women face based on socioeconomic status and race. But we've also heard about innovative work being done to close those gaps and create more equitable access to care. Thank you to all of the talented experts from across Canada that participated today and who day after day dedicate their passion, tireless work, and professional expertise to improving the health and well-being of Canadian women. But women shouldn't have to do all the heavy lifting. Men must also recognize that they have a vital role to play in this conversation as partners, colleagues, healthcare providers, and leaders. Their engagement and advocacy are also necessary to driving meaningful change and building a more inclusive and supportive healthcare system for everyone. Thank you to a man for starting that clap. Improving women's health is not just a women's issue, it's a societal one. Thank you again to all our speakers, sponsors, and all of you who joined us today, both in person and virtually. We hope you have inspired, informed, and ready to be part of the solution. We now invite you to join us for the networking reception out there. We can keep the conversation going. Thank you very much for joining us.